Good morning, everybody. Today I am discussing a case of right-sided periampullary semicircular canalolithiasis, that is the typical variant that transformed via the non-ampullary arm semicircular canalolithiasis to posterior cupulolithiasis. I have taken this subject because a recent paper from America by Olivia Culmanson and Carol Foster recently doubted the existence of cupulolithiasis either in the horizontal or in the vertical, that is the posterior semicircular canal. What happened to this patient is shown by this animation here. So this is a 61-year-old male patient presented with vertigo on turning in bed from left to right while supine and on getting up from supine. The positional tests done on day 1. As usual, we do a bow and lean test first. The lean nystagmus showed a vertical right torsional upbeating positional nystagmus is elicited. So we followed this by the right Dixal pike test that elicited a direction reversing positional nystagmus, possibly because of short term central adaptation of the vestibulo-ocular reflex. Initial strong right torsional upbeating crescendo decrescendo positional nystagmus of 19 seconds is immediately followed by left torsional downbeating slow crescendo decrescendo positional nystagmus of 45 seconds. So this is the lean nystagmus which we observed. I am leaning the head backwards, that is extending his cervical spine. And after a latency of few seconds, you see a upbeating right torsional nystagmus. So we followed this by the Dix-Hallpike test. The right Dix-Hallpike test showed an initial upbeating right torsional nystagmus of around 19 seconds. This is typical crescendo decrescendo. It stops and then it reverses direction. It becomes slow crescendo decrescendo, downbeating and left torsional. And it lasted for around 45 seconds. So we attribute this nystagmus to the short-term central adaptation of the vestibulo-ocular reflex. So, as is the usual practice at our center, we do Epley maneuver 5 times. That we did, and the uprighting from the right distal pectus showed the downbeating left torsional nystagmus. So there is hardly any doubt about the periampullary location of the right posterior semicircular canalolithiasis. Treatment with 5 cycles of right Epley maneuver was carried out, and 24 hours later we did a retest right Dixalpike positioning. At 24 hours, the right Dixalpike test shows a left torsional downbeating nystagmus, and this nystagmus is slow crescendo decrescendo, lasted for around 45 to 50 seconds. So possibly the patient had a intracannular switch from the periampullary location of the otoconal debris to the non-ampullary arm near the cross commune. Usually in the non-ampullary arm posterior semicircular canalolithiasis, the disc sulpictus to the either side elicits the similar nystagmus. First, we examined the reversal nystagmus. 1 to 2 beats of upbeating left torsional nystagmus were seen. Right torsional nystagmus were seen. We followed this by a left disc sulpictus, which also elicited a left torsional downbeating positional nystagmus, which is again slow crescendo decrescendo, attesting our assumption of intracanalar switch from periampullary to the non-ampullary location of the otoconal debris. Uprighting from the left disc sulpictus showed a reversal nystagmus, which is upbeating and right torsional. Usually, the reversal nystagmus is very rarely seen in cases of non-ampullary arm posterior semicircular canalolithiasis, but here we have been able to elicit it. So, how to deal with this apogeotropic right posterior semicircular canal BPPV due to non-ampullary arm semicircular canalolithiasis of right side? So this is what happened while we carried out the Epley maneuver 5 times. So we did quick liberatory rotation maneuver and then we did a demi-semont maneuver in the release position. I'm going to demonstrate this by this video. I'm going to perform the augmented demi-semont maneuver in this individual with apogeotropic right posterior canal BPPV. 45 degree to his right in the yaw axis and patient is taken briskly to the nose down position to his left. And now I'll put some vibrations on his mastoid. This is the Hitachi matching vent for delivering mastoid vibrations. The idea of giving vibrations is that in cases of apogeotropic posterior canal BPPV, the otoconal debris is often entangled, that is jammed in the non-ampullary arm near the crus organ. So, by giving the mastoid oscillations, we are trying to dislodge. It from the jammed portion of the canal. So again, for 15 seconds. And after being for 1 minute in this demi-semont position, we ask him to get up to the short sitting. Teji sitting. Stop. So then we did a retest disc sulpike positioning on the right side. After this, at 48 hours, that is another day later, we see initial 1 to 2 downbeats and then there is a right torsional upbeating positional nystagmus that is persistent, lasting more than 60 seconds. So it is a usual practice in our clinic when we see a persistent upbeating ipsitorsional nystagmus in the disc sulpike or half disc sulpike position. We do an inversion test to know whether the nystagmus reverses the polarity of its vertical and torsional component, and if it reverses, then for sure it is the cupulolithiasis which is causing this pattern of the oculomotor response. It is a slow nystagmus, slow crescendo, decrescendo, and persistent. Already it has lasted for over a minute and 10 seconds. So at any time after which the nystagmus is more than 1 minute duration, a inversion test, that is lateral recumbent to the non-involved side with nose down, is being done to look for the reversal of the vertical and torsional components, and indeed they reversed. In the left lateral recumbent with nose down, the nystagmus becomes downbeating and left torsional, suggestive of adherent type of cupulolithiasis. So this case throws some light on the genesis of posterior cupulolithiasis in patients who are treated with repositioning maneuver for the typical periampullary posterior semicircular canalolithiasis. So from the non-ampullary arm near the crust commune, the otoconal debris reaches the short arm and gets adherent to the short arm side of the posterior cupula after the mastoid oscillation augmented QLRM and the demi-surmount maneuver. So what happened that during the mastoid oscillations here, you see the lower labyrinth here on the right side of the screen. The otoconal debris breaks away, that is, it fragments. However, it did not get embedded into the utricular macula. And now you see the upper labyrinth. The otoconal debris now settles on the utricular side of the, that is the short arm side of the posterior cupula, as the patient is uprighted to the short sitting position. And that's how the posterior cupulolithiasis was the end result in this patient. However, with the bascule maneuver, we were able to readdress his cupulolithiasis in less than 24 hours. Thank you.